lighter it. So he starts now I'm around 750, well in the middle of everything. I blame that on the diet and eating all carbs.
It's a good sign of young and strong.
I see so many things, people coming up with all sorts of, rheumatism, back pain, and they all say, oh, I've gone low carb or I've gone carnivore, everything's gone.
Is there anybody
Any of those. At least I can feel it's a small.
Okay, part two. I'm David Unwin. I'm a GP from Southport, and my story is about 2012. I suddenly became depressed with being a doctor because things I did didn't seem to make a difference. I didn't see healthy people. I gave them drugs and more drugs, and they never got any healthier. And the whole thing was just too depressing for words. And I was considering leaving medicine because, I wanted to make a difference, and I wasn't. So I thought I'd do something else. And one of the particular things that first made me suspicious was the whole cholesterol debate. Because people would come to me and they'd say, right, Dr. Unwin, I've given up eggs, I've given up butter, I've given up everything you said. I can't wait for my blood results. Now, the clinicians in the room will know that they give up eggs, they give up cheese, they give up butter, the cholesterol hardly shifts. It was so depressing. I thought, I don't believe this. I simply don't believe it because I'm not seeing improvements. So that was me suspicious of eggs and butter and all the rest of it. And then in our practice, we'd suffered an 8-fold increase in the number of people with type 2 diabetes in my professional lifetime. So when I started as a young doctor, there was 57. By 2012, there was 470. So in the same population, we'd had an 8-fold increase in the number of people with type 2 diabetes and no money. No extra money, no extra nurses, nothing to help with these people. And again, we were auditing, what difference did our treatments make? And it was rubbish. It was terrible, the results. We were just adding drugs, nobody got much better. It was so depressing. And it's a separate story how one patient taught me what to do. She came in to complain, because she said I'd given her metformin for 10 years unnecessarily because she had sorted out her diet, come off her metformin, lost 3 stone in weight, looked fabulous, and she actually wondered if I was qualified. Imagine how scared I was. She was an angry woman. She said, you didn't think about your prescribing to me, Dr. Unwin, because that metformin gave me diarrhea, and I was too ashamed to tell you. And you never helped me. You never once told me that breakfast cereals were sugar, or that bread was sugar, or that rice was sugar. And that was the first patient who had achieved drug-free type 2 diabetes remission, the very first one. And fast forward now in the same practice, this Monday I found 2 more, and we've done 129. So that's 20% of the entire diabetic register. So we have changed the entire practice. There are 9 doctors and 3 nurses and the midwife, and we're all low carb, which you're going to hear about. So we're all low carb. I've been in ketosis for 9 years, so I run on fat. Now, in the early days, we had noticed astonishing changes in lipids. So that's why I'm here to talk to you, not about diabetes, but you haven't wandered into the wrong meeting. In the second half, it's not about diabetes, we are going to be talking about lipids. So there we go, cardiovascular disease. Are we blaming saturated fat for what the sugar actually did? Well, I don't know, but we'll pursue it, So 3 factors that are definitely linked to each other and mortality. Abnormal liver function. So you heard Scott talking about the liver is absolutely key to metabolic disease and metabolic function. Raised triglyceride, we were talking about triglyceride and how important it is. and type 2 diabetes, which is why I was linking the sugar and cardiovascular disease. So these things are linked, but how are they linked? So here is here's a patient. This is Chris, and at this stage he's 40 years old. He's got a very significantly raised triglyceride level. He's got fatty liver, abnormal liver functions, gamma GT is sky high, and he's got poorly controlled diabetes. Now, Chris was one of the very first patients who gave up sugar and put his diabetes into remission. And his diabetes has been in remission now since 2015. So we wrote his case up in the BMJ, and there he is now. He weighs 20 stone on the left, with out of control blood pressure, fatty liver, high triglycerides. The cardiovascular risk of Chris on the left is so high, so high. And yet there he is on the right. He's not on any medication of any kind. No statins, nothing for his blood pressure anymore. He's come off everything years ago. And what we've achieved for him, he's not a patient. He's a well guy getting on with his life. I saw him 3 weeks ago. But he's just getting on with his life, and surely this is what we're trying to achieve. And I sometimes think when we think about risk, it's a very blunt instrument, when what we need to do is think about the individual and what they are hoping for and how they feel about drugs. So in the early days, I noticed when we were doing low carb that liver function, gamma GT, would improve in weeks. I had no idea that liver function was as dynamic as that. And yet, week after week, they kept coming back better. So I became interested in liver function because I had people I was telling off saying, I had one lady, I had referred her to 2 gastroenterologists for fatty liver. And every time she was told off for drinking. And she was such a nice lady, and she said, I do not drink. I am not a liar, I do not drink. And that woman, when she went low carb, her liver function, her gamma GT used to run above 150 and had done for a decade. Within 6 weeks of going low carb, she was in the normal range and has been for 10 years now. So I became really interested in liver function. So our computer systems are wonderful in practice. So we did an audit, and 24% of all the liver function tests, the gamma GTs done in my practice, which was 1,153, were abnormal. Isn't it quite astonishing that 24% of all the blood tests should be abnormal? What is going on? And does it matter? Well, the answer is it does matter, because many of you will have heard of the Framingham study. This is the amazing populational study in America looking at cardiovascular risk. And what the Framingham people said, they followed up thousands of people for 19 years. If you were in the highest quartile, if you were in the top 25% for gamma GT, you were going to have a 67% increase in the risk of cardiovascular disease. So that is astonishing. If you're talking about risk, that is way beyond what LDL will ever do for you. LDL does not predict a 67% increase in cardiovascular disease, but gamma GT does, and that's from Framingham. So isn't that interesting? So my interest was sort of, I'm on about sugar, and then I'm thinking, liver function, what is going on? And why are all my patients sick with abnormal liver function? Are they all drinking? What's going on? That's the reference for that. So actually, 25% of the entire developed world has non-alcoholic fatty liver disease. So 25% of the people in this room, 25% of your patients, your friends, your relatives have fatty liver right now. And it matters. But why is it there? And why aren't we talking about it if 25% have it? And there's the reference, because it's important that you believe what I say. So the next thing was triglyceride levels. the funny thing about triglyceride levels, so we audited that as well. And in this case, 32% of everybody that had a triglyceride level at Forward Avenue had a result above 2. So that was loads of them. So what is going on? And also, does it matter? And there you have the reference. Again, we were talking about, so elevation in the ratio of triglyceride to HDL is arguably the single most powerful predictor of extensive coronary heart disease. And there are 2 references for that. So triglyceride really does matter. And I was ashamed when I discovered that, because I don't know what the clinicians in the room do about triglyceride, but what I used to do was, I'd say to people, they'd say, how's my cholesterol? And I'd say, it's fine. You've got this thing called triglyceride and it's up a bit, and they'd say, well, does that matter? And I'd say, I'm not really sure, but we'll redo the blood test in a year. Okay, that's me fudging it. Lose a bit of weight and we'll redo the blood test in a year. That's pathetic. It's because I didn't know, so I fudged it. And triglyceride did matter. And again, I have come to believe that we must focus on triglyceride in primary care, because we don't have the sophisticated lipid profiles, but we do have triglycerides. And some practices don't do fasting lipid profiles. And if you don't do a fasting lipid profile, you can't know what the triglyceride is. And it's absolutely key to deciding on how much risk is your patient at and why, and explaining to your patients. Because we need to demystify. If you just medicalize people and tell them what to do, I find they ignore me. That's what they did before, they just ignore me. But if I can explain what their problem is in a way they can understand, they take action. And that's why we get such good results in Part and Ward Avenue, because we've got good at communicating with our patients and explaining why sugar for them is so difficult. So there's triglycerides, and it does matter. And so insulin is absolutely linked in with this. As I was explaining before, nature controls dangerous things very finely. So things like potassium, things like sodium are controlled in a fine level. You can kill people with a high potassium, can't you? It's like the perfect way to murder somebody, isn't it? Potassium. Well, sugar is controlled in this way because it's dangerous, and it's controlled by insulin. What does insulin do? Insulin pushes sugar out of the bloodstream where it's damaging the glycocalyx, and pushes it inside cells where it becomes fat, and that fat is triglyceride. So there's a clear link between dietary sugar and triglyceride and cardiovascular risk, and insulin's in there with it, and it kind of explains the type 2 diabetes thing, because in type 2 diabetes your insulin can't do its job anymore, and so you're losing control of the blood sugars and the glycocalyx is damaged. The pancreas also fills with fat, by the way, so the liver fills with fat. So if you carry on eating Mars bars and bread and rice and breakfast cereals, if you have sugar all day long, that is how you end up with fatty liver. And a quarter of us have it already. That's not quite the whole story yet, though. This is the work of my friend Professor Roy Taylor. He's at Newcastle University, and some of you will have heard of him. He's a very famous expert in diabetes. And his expertise is understanding why do people become diabetic. And this slide explains it. So that's me there, and as I continue to eat biscuits and bread and rice and pizza and chips and more rice, my liver is filling with fat. And fatty liver interferes with the work of insulin. So you become insulin resistant because of fatty liver. And Roy Taylor talks about the long silent scream from the liver. There's a 10-year gap between your liver filling up and you losing control over the blood sugar. And that is why abnormal liver function and triglycerides are giving you some early warning of what either might become type 2 diabetes or can become cardiovascular disease. And at the same time, this is the double whammy that causes type 2 diabetes, because your pancreas is filling with fat as well, interfering with the work of the beta cells that are there to produce insulin. So you get a double whammy where your insulin doesn't work as well because of fatty liver, and your pancreas is struggling to produce that insulin because it's full of fat. Just finish with that. The good news is that all of that can be put into reverse. So you saw Chris, whose fatty liver is in reverse, his triglyceride is reversed, and his blood sugars have been normal for years. So that you can put it in, you can reverse it. Bariatric surgery also reverses diabetes. Fasting does. And then Roy Taylor's, probably you've heard of the shakes and soups, very low calorie diet. So there's different ways to reverse diabetes, but we're thinking now about lipid profiles. So here's a patient, synchronously, you're looking here, you're looking at, so this is one patient, 2 graphs of their serum triglyceride from 2010 to 2021, and the hemoglobin A1C from 2010 to 21. And you'll see for this patient how closely triglyceride is matching what's happening to the hemoglobin A1C. So I'd really say if you've got a raised fasting triglyceride, please don't ignore it, because that's a little message of problems to come, particularly if they have a big belly, particularly if they have high blood pressure as well, and particularly if the liver function is off. Our whole practice has become more and more sensitive to these high triglycerides. And we discuss it with patients. We say, so in this afternoon's clinic, I'll have said to 3 patients, have you gone a bit sugary recently because your triglycerides double what it ought to be? Oh God, yes, it's the biscuits. Shall we measure it again in a month? Yes, it'll be fine. So they will, people, when they understand the link between sugar and triglyceride, they'll give up the sugar for you. They don't, people are intelligent, they don't want to be ill. They really don't. It's just a way how you're going to communicate this to them. The other slide just showed that that person had sustained drug-free type 2 diabetes remission. So that was, it can go on for years if they stick with the diet. So why have I put this in? Oh yeah. So this is a sky-high triglyceride, 20.88 in January 2021. But look, his hemoglobin A1C was 92. So it all makes sense. So I just wonder what some of you might have done with a triglyceride of 20, because statins aren't going to solve that. But it makes sense when you see it in perspective, thinking about the liver, thinking about sugar and the way the body, once your glycogen stores are full, the only thing your body can do is turn sugar into fat, and it's fat in the liver. But look how rapidly, I was telling you how rapidly it can improve. So that guy's triglyceride went from 20 to 2.1 in 3 months, and his hemoglobin A1C went from 92. Most people are reaching for the prescription pad at 90. They are panicking. I didn't use any drugs at all. And he got drug-free remission. So that guy went from being dead scared, very sugary, lethargic and sick, and now he knows how to look after himself. We have taught him, rather than medicalising him, giving him drugs, he's learned how to look after himself. He's not scared because he knows why he was ill and what to do about it. So he's not really a patient now because he's in drug-free remission. I'll need to keep an eye on him, and I shall be monitoring his triglyceride. Moving on. A high blood glucose is linked to a high triglyceride level. I've said the same thing about 3 times. Right, this is the worst lipid profile I had ever seen, and the nurses in the practice couldn't wait to see what I did with it. So they sent this guy to me. So he's got a hemoglobin A1C of 79. his serum triglyceride was 38.9. Has anybody in the audience got one that will win? Better, worse than that? We do it like a sweepstake in the practice, or we say, who's got the worst ever? So this guy won. Triglyceride of 38.9. I think Scott has seen a higher one, so he would beat me on that. But he is
the muffin man.
Yeah,
We had
he's
four muffins for breakfast, and he had can't remember what he had for his lunch, but his evening meal was 2 Chinese meals every night. And yeah, his was 90 something, but
Wow.
came down to like 7 just by changing his diet. And he ended up on a statin him anyway, but.
It'd be interesting. I mean, if you spun down his blood, the fat level in there must have been amazing.
If you eat 4 muffins for breakfast,
Yeah. So this is my Scott's won me already there, but again, look, the triglyceride 38.9, the cholesterol HDL ratio was 15. So that looks really bad, doesn't it? Cardiovascular risk. But what we have to do, we were talking about risk before. Why? What is the risk? Let's not just hit this person with a hammer, a vague kind of statin hammer. The problem, when I went into it, was an astonishing diet. And when I said, you know, you've eaten your way into this crisis, this is really serious. He said, right, I better do something. And as you see, so that is within 14 days, the triglyceride had come down from 38 to 9. Well, 9 isn't good, but it's only 14 days, and he has improved it since then. And the cholesterol HDL ratio is halved. All we did there was he understood what his risk was and how he'd come to get it. And this link between sugar and triglyceride and liver. And he wasn't surprised. He knew he said, thanks, I needed a kick up the bum because I know my lifestyle's terrible. And he needs ongoing support, but he's still improving. His hemoglobin A1C now, the latest one actually was 3 weeks ago, is 52. So he's all aspects of his risk are coming down, and his blood pressure's better as well. And no single drug would achieve that, not blood pressure, triglyceride, cholesterol, HbA1c. We may come on to SGLT2 inhibitors later because there's a member of the audience who wants to talk about those. We'll see. So now we're coming to the overall results. So what we did in the practice in the early days, if you go low carb, if you're cutting out one of the 3 macronutrients, well, you're eating more of the others. So I got a lot of flack and hate letters, all sorts of things, and I was booed and hissed on stages in the early days because people had concerns about the cardiovascular risk of my patients because they're eating butter, cheese, loads of meat, that kind of thing. And so from the very beginning, I've got 10 years of careful data on cardiovascular risk. So this was published in January in BMJ Nutrition. So if you think about what are the cardiovascular risk markers? Well, smoking is one, but I can't pretend that low carb is going to cure smoking, so we haven't put that in. But if you look at the weight, so people were losing, this is at an average of 33 months. So this is baseline, each graph is baseline on the left, there's baseline on the left, and latest follow-up on the right. So weight, this was 186 patients for nearly 3 years. The weight, they had lost 12% of their body weight on average. The hemoglobin A1c was improving by about a third. If you look at any treatment for diabetes, it brings it down by about, that's 27%, but usually you might get 8% improvement. We're getting a third. The results at the beginning were so good, I was scared because I thought it made me look like a fraud. I didn't dare publish it because I thought I would be marked as a fraud because drugs never do this kind of thing. And it was Roy Taylor who I wrote to 20 professors to say, I found this thing, I think it's important. what shall I do? And only one person answered, and that was Roy Taylor. And he said, it's astonishing, it's brilliant, and he did the stats for me. So moving on, triglyceride. You won't now be surprised to see that the triglyceride, on average, is improving by a third. Drugs just don't do this. They don't improve stuff by a third. So that is amazing. The blood pressure, the systolic was improving by about 11 millimeters of mercury and the diastolic by 6. And that's despite stopping 20% of all the drugs for high blood pressure. So the improvements in blood pressure are actually even better than that, because I'm taking so many drugs out because people were feeling faint when they stood up. And that actually Scott and I, we published on that, didn't we? Separate one. The cholesterol there, the total cholesterol improving by 12%, and the cholesterol HDL ratio improving by 2%, which isn't much, but the p-value was very good because so many patients got a small improvement. So that was the results for the practice, what we're achieving. This is real world data. So this is ordinary people in Southport, not far from here. And this work has been replicated in plenty of other practices. I really highlight the Freshwell practice, David Oliver in the Freshwell practice, who's doing exactly this. Only they've got a brilliant free low carb app, which you can download for free, based on the work at Norwood Avenue, and it's Kismet approved now, so it's approved within the NHS that you can refer people to the Freshwell app for them to go low carb if they want. This is a separate publication on gamma GT. Probably the best thing to look there is the pie chart on the right. So we were following up 95 people, baseline and latest follow-up on the gamma GT. The gamma GT normalized, so they got a normal gamma GT in nearly 3/4 of the cases. Again, that's kind of astonishing, and you can see why I was scared to publish it, because it just sounds too good. But those are the stats. Yeah. So let's have a look. Here's somebody. We're looking at 3 graphs this time, one on top of the other. You've got the gamma GT at the top, you've got the triglyceride, and you've got the serum HDL cholesterol. And the blue line is where that person went low carb. So what you've got here is years of a raised gamma GT. More acutely, the triglyceride was going up, and the HDL was low. So remember, the HDL is protective. So the cardiovascular risk for that person with abnormal liver function, high triglyceride and low HDL is really bad. But look what happens for the years since then that this person has been low carb. So we've normalized the gamma GT, the triglyceride's been within the normal range for 8 years. 8 years. And the HDL has been significantly higher for those same 8 years. So that's the latest follow-up is March 2023. So we were talking earlier, weren't we, about the triglyceride HDL ratio, which is a respectable, it's a proxy really for insulin sensitivity and gives you an idea of what's happening metabolically. So the triglyceride HDL ratio in 2015 was 1.93, and 8 years later it's 0.73, so it's improved by 260%. Again, so that's just to dream of, this improvement in cardiovascular risk for that person. And she's very grateful because she weighs less and she's not taking any medication, and her blood pressure's normal as well. And there's that reference. Elevation in the ratio of triglyceride to HDL was, in this study, the single most powerful predictor of coronary heart disease. So ignore triglyceride at your peril, but do make sure it's a fasting one. Do make sure it's a fasting one. And in fact, we have now, this is the expert consensus decision pathway from the American College of Cardiology. So this is right from the top, and it's saying this is what to do for hypertriglyceridemia. And basically, depending on how bad the triglyceride is, you're going to cut back on sugar, sweetened beverages, desserts, sweets, cookies, cakes, pies, pastries, table sugar, jams, jellies, and avoid starchy vegetables. So it's a low-carb diet, and that's published in the guidelines. So it's completely reasonable if our triglyceride is high to think about a low-carb approach. I'm not saying it's the only thing, but it's reasonable. So there we are. In my practice, I haven't discovered that saturated fat makes much difference. And my patients are eating more full-fat dairy, they love cream, they're having it, they do eat a lot of meat, but honestly the cardiovascular risk for them as a group has improved. So I think the vilification of saturated fat, I just wonder whether it's true. I do use statins, but not for primary prevention. I'm using statins for people whose cholesterol worries me and not for primary prevention. I'll always try this first. I'm saying to the patients, do you want to start statins today? Or are you interested to do a lifestyle approach? What do you want? Because it might also improve your blood pressure and get rid of your belly. Just about nobody goes for the drugs, and that's why at the practice we save so much on the drug budget. So we're saving £80,000 a year on it's £70,000 a year on the diabetes drug budget, because I've done the same with metformin and insulin. So I've said for 10 years to patients, do you want to start lifelong medication today, or are you interested in changing your diet? And not a single patient has said, give me the metformin, not one. And that is why the savings that we make are bigger every year. Every year, the difference between us and the surrounding practices, this is monitored by open prescribing. Every one of us is monitored by openprescribing.net, so you can check your own prescribing on there. And I think I'm just about done.
Thank you, David.
Yes, I have.
Thank you. Can I just say a disclaimer, if you are over your calorie budget and you eat more saturated fat,
Yes.
you will get fat.
Yes, that's true.
And it will affect your lipids.
Yeah, that's
You
true.
need to be under the calorie threshold.
Yes.
Or you are, you can't just nail cheese and cream and butter and bacon and then, you're gonna cure everything. You need to be under your calorie threshold. Is that fair? Or it'll just go into your fat
I
stores.
think so I have people who don't lose weight but whose cardiovascular risk improves, and so I'm not sure they're under the calorie threshold. And then again, you've got people who can store fat safely. I just don't know.
It depends. It's individually. And if you want to know whether you're fat for yourself, are your fat cells happy or not? You can measure adiponectin, but you won't get it on the NHS. If your adiponectin's low, you're fat for the size for your fat for your body. If your adiponectin's high, you don't need to worry. So there's loads of people who are physically fat to look at, but their adiponectins will be normal or high. And it's because their fat cells are happy.
And a proxy for that. So I'm always looking for humble proxies. I think inflammation is so. Just CRP, ESR, the white cell count. The white cell count. So you always do a full blood count every time you do a hemoglobin A1C. The white cell count is well linked to inflammation, so that we're already doing blood tests that are supplying information. If I can't get insulins, I can't get any of those things, but I can look at inflammation, I can look at white cells, and that gives me extra information as to how at risk the person in front of me is. But probably will change, and we will get those blood tests eventually, but
Yeah.
I can't at the moment.
We're going to move on, and where's Julia going?
Oh,
you're there. So Julia's going to give us a quick story, a patient story. I'll introduce Julia now. I'll put the lights up for you, Julia. Is that alright?
Well, mediocre, not too bad.
Alright, I'll move you on.